we've talked extensively about probably the three most advanced treatment protocols for spinal muscular atrophy, and there's so much more to come. There have been trials in the past with other supportive treatments, things that we're looking at neuroprotection, things that we're looking at supporting neuromuscular transmission, improving power generation from muscle cells, improving muscle regeneration. And some of these are ongoing, some of these were done. But these are not specific to spinal muscular atrophy. So the whole question about whether combinations of these gene therapies or combinations of these with other supportive therapies would be optimum for children or adults with spinal muscular atrophy, and which ones at which age, I think is are unanswered questions that we're all looking forward to discovering together. But I think there are two things that I would like to circle back in the last bit of time that we have here. And one of them would be to say that we wanted to touch base on newborn screening and the need for it, and what these current treatments and therapies, what perspective that gives us on the effort to promote newborn screening. So maybe we could start, Claudia.
Well, absolutely. I think all of the studies that have been discussed show that even if it's later onset SMA or infant SMA, that early treatment is important, and there's a differential response to early treatment, with the ASO treatment showing the best response and possibly normal development. I think it'll be very exciting to see on an equal playing field these pre-symptomatic studies that are ongoing that will be comparing the small molecule risdiplam, the AVXS-101 with the SPRINT study, as well as the NURTURE study, to see if there's any benefit or advantage to one over the other. I think the issue of whether you have a CNS restricted therapy like nusinersen versus something that is more widely disseminated makes a difference. My own approach to that is for the symptomatic child, especially the infant. The Firefish data is very exciting that they can salvage babies that are that much older. Whereas with the AVX-101, if the older child didn't seem to respond very well, and there was a differential response if they were under 5 months or later than 5 months, and the response was kind of flat once they got past a certain age, which may reflect a critical number of neurons that you need, that if you're more advanced, there's not enough gene to produce it. But so far we don't know, because a lot of the nusinersen babies are doing very well. So CNS restricted, if you start early enough, may be enough to make a difference. So we'll have to wait to see if indeed you need combination therapy when you treat pre-symptomatically. When they're symptomatic, I think it's a different story, because you want to maximize SMN, and then combination therapy with a gene transfer and an SMN2 splicing modulator, either risdiplam or an ASO, may make sense if we're permitted to do so. The studies in the pipeline now that are using ancillary drugs that are not SMN specific but that enhance muscle are another issue to use in combination with an SMN modifying therapy. So I think it'll be exciting to see how much benefit is given. One question that always comes up is if their supraphysiological SMN protein levels are toxic, and it doesn't seem to be the case. And it seems like if you have more SMN and you're more affected, that might improve function even further than if you use one, which would be a reason to use combination therapy in children who are a bit more advanced.
Basil, what are you thinking?
I think Claudia covered the topic very, very nicely. I don't have a lot to add, except to say that that in addition to preventing the disease, we have to realize that we may also do something that diminishes the cost of the disease, because you're not just having a child who has normal motor development, but also we have a child who does not have to be admitted to the hospital multiple times, and sometimes into the intensive care unit, which is, as we all know, it can be quite expensive. The other point I would like to make is that we tend to forget the value of the preconception carrier screening, which aims at diminishing the number of babies who are born with SMA. And as I said at the beginning, one every 50 people in the general population are carriers of this mutation, which means that it's quite common. And it will help enormously in the preventing the disease if prospective parents are screened for carrier status around the world.
And SMA has been on the recommendations for obstetrics and gynecology for testing since 2017. And so certainly it seems like it's being done a lot more broadly, although I think there are limits to that type of carrier screening, because it's important to remember that that's screening and not testing, that I think sometimes not everyone is aware of. So important limitations are that primarily it does testing for the deletion, and not for sequence variants, which, as we mentioned before, would miss about 5%. And also, particularly in certain races, there are a higher percentage of people who may have 2 copies of the SMN1 gene on 1 chromosome. It's particularly true in African Americans, and so the sensitivity of carrier testing in them is only between 70 and 80%, while it's well over 90% in Caucasians. And so really kind of trying to think about those limitations in the interpretation of this, I think, is also important. And newborn screening could help fill in some of those holes, although it will still miss some of them.
I'm aware that some legislation has been passed in Australia to try to do nationwide preconception counseling as a strategy to minimize the occurrence of spinal muscular atrophy. So imagine we'll hear from them and our colleagues overseas about their experience.